Hello, my name is Melissa Elliott. I'm one of the nurse education coordinators here at St. Joe's, Oakland. And today I'm going to talk to you about restraints. So I'm sure many of you, whoever's watching this, have applied restraints before. And if not, it will likely happen in the next year. So the first thing we're going to do is go over some restraint basics. So first thing, we always want to attempt alternatives to restraints first. So maybe your patient is picking at that IV, so maybe we cover it up. Maybe they're just really fidgety, so maybe we print them something from Google. I'm not endorsing Google, but we print out a Sudoku or a crossword, something like that, something that keeps them busy. Sometimes we just have to think outside the box. Next, the type of restraint we use should always be the least restrictive possible. We never want to start with the twice as tough cuffs unless it's absolutely necessary. So maybe we're starting with mitts for that patient, as some would say, the pickers and pullers who are just trying to pick at that IV. Next, a provider's order is required for all restraints. Restraint should be discontinued as soon as possible, and the use of PRN, physical restraint orders, are prohibited. So what that means is that if I have a restraint order and the restraints were put on at night and I come in on day shift and the nurse tells me, yeah, they seem to be getting a little bit better. So it's my shift with the patient, and after a couple hours, the patient does seem to be doing better. So I go into the room and I'm going to do an assessment, give some medications, help them order lunch, get them up to the restroom, help them brush their teeth. So I'm going to be in there for about 20 to 25 minutes, let's say. I'm providing patient care, and because of that, and I'm in the room with the patient, I'm able to take their restraints off. I take it off as soon as I get in there. I'm in there for 20, 25 minutes, and my patient is starting to act a little more confused again, starting to want to know why the PICC line is in, and they try to play with it a little bit. And I say, I don't think they're quite ready. I'm able to put those restraints back on. I was supervising my patient the whole time. I was providing patient care. I'm able to take the restraints off and put them back on. However, if I had taken the restraints off, left the room, and 2 hours later, my patient needed them put back on, that's considered PRN restraint, and I would not be able to just reapply them. I can put them back on, but with a brand new order. We also want to make sure that we're letting the family know that restraints were applied and why. If you think about it from your perspective, you would never want to walk in and find a family member in restraints if you were never notified prior to coming in. That could be really upsetting for a family member. In an emergency situation, we are able to initiate restraints and apply them by a qualified professional, but we must get an order either during or immediately after. If the attending physician is not the ordering provider, the attending physician or covering physician must be notified within 1 hour after the order is entered. This can be done via telephone. The patient must be given an explanation why the restraints are being applied and what the criteria is for their discontinuation. If restraints are removed for any other reason than to perform patient care, the order must be discontinued. And again, if the restraints need to be reapplied, we have to get a brand new order. A physical restraint is a physical or mechanical device, material, or equipment that immobilizes or reduces the ability of a patient to move his or her arms, legs, body, or head freely, or prevents functional use of hands. We have the mitts, which some people will ask us. It's been seen in Epic. It will say secured mitts. Our mitts are not attached to the bed. However, according to the definition of a physical restraint, this prevents functional use of hands, so it is considered a restraint. Another example is our soft restraints. We have our hard restraints, posy bed. Some people have seen these, some haven't. 4 side rails up is considered a restraint. And then tucking a patient's sheets in so tightly that the patient cannot move. And I think if you've been a nurse for a while, you, like I, were probably taught this at the beginning of your career. However, it is a restraint. These are our examples of restraints here. So I will show you these. We have our mitts. And if you see, the mesh is on the back of the hand and the fluffy part, the cushion, is on the palm. These are our soft restraints here. These are our twice as tough cuffs. The 4 side rails are up here. And then we have our posy bed. When you saw the soft restraints, you saw that there was a clip, and I'm sure a lot of people remember hearing about the quick release knot in school. So as you can see here, this clip takes the place of the quick release knot. In case of an emergency, you simply squeeze here on both sides, and it is a quick release. Now, as you see in these pictures, we have a check mark and we have an X. So this is what the restraint should look like when being applied to the bed. Restraints, when attached to the bed, should be attached to a non-movable part of the bed that moves with the patient. So if this bed is raised up, it's going to move with the patient, okay? Now, if you look over here, this restraint was tied around the side rail. It is tied under the bed, but it's also tied to the side rail. And as nurses, we're pretty guilty of going into the room and maneuvering the room how we need to accommodate our workflow. There are a number of times I go into a room and I need to straighten sheets or pull a patient up, and I always put that side rail down. Now, if I put that side rail down and my patient is in restraints, I'm pulling their arm way to the side when I drop that side rail. If you have it tied under the bed here, you should never tighten it, make it tighter to the patient by wrapping it around the side rail. So if you've used a posy bed before, some people love it, some people hate it, but the posy bed can be very helpful. This is our algorithm for deciding who is a candidate for the posy bed. If you need one, we simply call this number with agility down here, this 248-348-3585. We have inclusion and exclusion criteria. Our inclusion criteria includes the patient is restless or agitated. They're impulsive, lack of self or body awareness, inability to follow safety requests, attempts to climb over the bed rails, and the posy bed does require a non-violent restraint order. So when I think of patients who may fit this criteria, I'm thinking of a patient with dementia or delirium. Often we have patients who have traumatic brain injuries that may go in here. Patients with cerebral palsy. I'm also thinking of patients that have encephalopathies, maybe those have a hepatic encephalopathy. And those patients are very hard to reorient. They're very restless. They would be a great candidate for this bed. Now, while there's inclusion criteria, there's also exclusion criteria. If the patient is combative, violent, or aggressive, if they are a suicide risk, if they have multiple lines, if they're claustrophobic, if they have a pica eating disorder, weight, if they are less than 46 pounds or more than 300, or if they are less than 46 inches tall. Now, looking at the weight criteria, we must follow this inclusion and exclusion criteria. Patients have tried to tip these over in the past, so know how much your patient weighs before you put them in here. Next, we have chemical restraints. So a chemical restraint is a drug or medication or a combination when it's used as a restriction to manage the patient's behavior, restrict the patient's freedom of movement, or to impair their ability to appropriately interact with their surroundings, and is not an approved use for the patient's condition. So if your patient is taking Ativan to treat their anxiety, it's not a restraint. But if we're just giving Ativan to control their behavior, it is considered a restraint. So if you've ever had a patient in violent restraints, these patients are assessed as being in extreme danger of injury to themselves or others. For these patients, we are expected to remove their restraints every 2 hours for not less than 15 minutes, unless medically contraindicated. If when you go in, your patient is still agitated and aggressive, verbally aggressive, their face is red, and you can tell that if you take those restraints off, they're going to swing at somebody, that patient should not have their restraints removed, and that is considered to be medically contraindicated. There are safety considerations when using violent restraints. Typically, the violent restraint order is associated with our twice as tough cuffs. I would like to put out there that it's important to know that the reason your patient is in restraints is what guides your restraint order. So just because your patient is in twice as tough cuffs does not necessarily mean they have a violent restraint order. That is typically the case. However, it is not always the case. So just remember that the reason the patient is in restraints is what guides the order for violent or non-violent. If the patient is in violent restraints and they have the twice as tough cuffs on, they need to have the key to unlock it taped on the whiteboard in the room at all times. As soon as the restraints are applied, that key needs to be taped to the whiteboard. For safety considerations, our policy states that one-to-one constant direct supervision is required for all patients in violent restraints. These patients are never allowed to have access to any tools, utensils, or objects that might be used to unlock or damage cuffs. Per SGML policy, we check the patient regularly to ensure circulation is not impaired and cuffs are secure. This is every 15 minutes. And again, here we have this stated, the key to unlock restraints is to be taped on the whiteboard in the patient's room in case of emergencies. The procedure for violent restraints, per our procedure, the nurse manager must be notified immediately of any instance in which the patient remains in restraint or seclusion for management of violent, self-destructive behavior purposes for more than 12 hours, or if they have 2 or more separate episodes of restraint or seclusion within the duration of 12 hours. After that, the nurse manager can be notified every 24 hours if either of these conditions persists. For forensic restraints, these patients are usually, they are brought in, I apologize, they are brought in with law enforcement, and law enforcement officials stay with the patient the entire time that they're in the hospital. Under no circumstances are hospital employees to apply the law enforcement restraint devices to patients. If the patient is in handcuffs, these are managed strictly by the law enforcement officials. So we have 3 different types of restraint orders. We have nonviolent, violent, and seclusion. Our nonviolent restraint orders are good for 24 hours. The physician must complete face-to-face within 24 hours of application. Real-time assessment and charting must occur at least every 2 hours, and the provider must evaluate at least every 24 hours. The every 2-hour documentation is prompted through our EPIC work list. For the violent restraint order, the provider must complete a face-to-face within 1 hour of application. The length of time that the order is good for is dependent on the patient's age. Typically, for most of us, we're going to see that the order is good for 4 hours, and that's if the patient is 18 years or older. The order is good for 2 hours if the patient is between the ages of 9 to 17. And if they're under the age of 9, then it's only good for 1 hour. So this does happen. we do have a pediatric unit, and I think it's seen more in the ER. With a violent restraint order, the patient is required to have one-to-one continuous observation. Real-time assessment and charting must occur every 15 minutes, and physicians must evaluate face-to-face at least every 4 hours. So a couple things I want to note for you with the violent restraint order. So the documentation must occur every 15 minutes. What is unique to our policy here at SGMO is that this 15-minute documentation is able to be completed not only by the nurse, but by the PST, a mental health tech, or a medic. So when this patient has a one-to-one continuous observation, we communicate this, that the patient is in violent restraints, to our clinical house supervisor when they're providing staffing. And we try to get a PST, mental health tech, or medic to be the ones doing the observation with this patient so that they are able to help the nurse with the documentation. I want to note that sitters, we do have actual sitters in the hospital, and sitters do not have access to Epic, and so they are not able to document in Epic and do the 15-minute documentation. Now, in addition to the every 15 minutes, there is another piece of documentation that must take place every hour. That is solely for the RN. If there is a sitter with the patient, then nursing is required to ensure that the documentation and assessment every 15 minutes is completed, as well as what's required for the every hour. We also have seclusion. This is only used in behavioral medicine, which is our 6 East floor. Here at St. Joe's Oakland, we have an area called the BOB, the Behavioral Health Observation Area. This is an extension of our emergency department, and we're very fortunate to have this here. So what are some of the benefits of, we call it the BOB? It's quiet. This is an area away from the main ED. They have the ability to separate these patients from 24/7 typical ED environment. If you think about having a patient who's they're having a manic episode, they've stopped taking their medications, maybe they're bipolar, schizophrenic, they're pacing, they're hyperverbal, they're easily agitated, and they're pacing next to a 90-year-old who's in for a UTI and a little bit confused. In that situation, they have the ability to agitate each other. So if we're able to take the patient, because sometimes patients who are in for behavioral health purposes, they may come into the ED, and while waiting for placement, they could stay down there for up to a week, maybe 2 weeks, and it's happened before. There are limited mental health resources available, and so they may have to stay down there for quite some time. And imagine being down there with the EMS phone going off because somebody's coming in, and the constant stimulation, the lights, the sounds. It's a lot for behavioral health patients. So to be able to have a separate area for them is incredibly beneficial for them. This area also has dim lights because these patients aren't laying in the hallway under the fluorescent lights. There's diversional activity. The area has a lounge with TV and reading material. Games and puzzles are available. And 6 East, our inpatient psychiatric unit, we have activity therapists up there, and they're often available to come down and do direct activities with the patients in the BOB. There's also privacy. Each patient has their own room with 3 walls, which is much different than being in the ED hallway. There's a shower available. It's safe. The area is designed to eliminate ligature risks. Bathrooms are ligature free. All the furniture is weighted, and patients have to meet certain criteria to go over there before they're able to be transferred. So what's required of a restraint order? We have to have this says physician, but a provider order that's signed, dated, and time. We need to know the clinical justification for the restraints. So why are they going in it? The type of restraints, how many restraints are being applied, and the duration of the restraint. The duration of the restraint is 4 hours for violent restraints if the patient is 18 and older, and the duration is 24 hours for non-violent restraints. It can always be stopped early, but when the order goes in, the duration should be the 4 hours for violent or 24 hours for non-violent. Again, we've talked about this. Do you need a new order or not? What needs a new order? If your restraint type changes or if the number of restraints you have on changes, you need to get a brand new order. The order can't be modified. We can't just go with it and document differently. We need to discontinue that order and initiate a new order. So if you come in and your patient is in 3-point restraints and you're able to take the third restraint off of their ankle and now we just have bilateral wrists, that means a brand new order. What does not need a new order? That is when we're in the room, we take the restraints off because we're providing patient care, and then we put the restraints back on when we're done doing patient care and we're then leaving the room. When you renew a restraint order, if you renew the order before it expires, you are just renewing it. If your order expires and you have to do a new one, you're initiating it. So when you're in Epic and you type in restraint, these are the 5 things that are going to pop up. One order is to release the restraint. The next thing is a non-violent restraint right here. And then you'll see here we have the 3 different orders for violent restraints. Remember when you're making your selection that you do it based on the age of your patient. This is what that restraint order looks like when I select on that non-violent restraint. I'm doing a continuous order for 24 hours. Again, for 24 hours. What time is it starting? This is where I'm selecting my restraint type. I'm selecting the soft wrist restraint. I want to note here that if you are putting your patient in a posy bed, we don't have an option for a posy bed or an enclosure bed, so you need to select other and then type in posy bed. But for this case here, we're doing soft restraints on the right and left wrist. And what's the reason why? Because of interference with medical equipment. And then we accept the order. So the next thing, we look at our work list and we can see here, we have our initial restraint assessment here. Sorry, it's hard to highlight on here. And then we have our restraint education, both of which need to be completed. So when I click on my initial restraint assessment, this is what's going to show up. Now in this top box that I have highlighted in red here, this is what we need to click on, okay? A lot of this has already been put in the, oops, I apologize, I need to go back. Sorry about that. A lot of this has already been clicked on. What's the length of the order? 24 hours. The assessment, what were the least restrictive alternatives we tried? So did we try repositioning, verbal redirection, decreased stimulation, diversion activities, things like that? The clinical justification, were they pulling lines, tubes, removing equipment, removing dressings, whatever's appropriate. Our visual check right now, when I am initiating it, what is the patient doing? Are they agitated? Are they hallucinating? Are they delusional? What's going on with the patient? I'm looking at circulation, no signs of injury as I have just put this on, or maybe the patient prior to me putting it on already has bruising in that area. So we want to make sure we're documenting that really thoroughly when we're initiating it. So range of motion, did we perform it? Did the patient decline? Is the patient asleep? Fluids offered, declined, patient asleep, patient NPO, fluid restriction, what's appropriate here? Food and meal, did they eat anything? Were they asleep? Did they decline? Are they NPO? And then elimination. Was it offered? Did the patient decline? Do they have a catheter? Are they incontinent? Are they asleep? So all of that needs to be filled out. In this blue box at the bottom, it says restraint type. We're only clicking on the boxes that were put in the patient's order. So in the order that we just saw, we documented on that we were initiating the right wrist and the left wrist. So I'm going to click start here, and I'm going to start here. Okay. If I was continuing an order, I would click on continued in this box, but because I'm initiating the order right now, the patient hadn't been on restraints prior to this, I'm starting this order. Now I want to show you on here that, let me change this color so I can point it out to you. If you see down here, here is where it says other. This is where if your patient is in the posy bed, I'm going to click on start, and then I'm going to comment here and add in my comment that it's the posy bed. I also want to show you here where it says side rails and chemical. Some people, when they start documenting on restraints, they want to just click all the buttons to make sure everything is documented. In this spot where it says restraint type, if you click on side rails up and if you click on chemical, you're stating that you're using them as a restraint. The only things that should be documented in this section are what is in your restraint order. It needs to match 100%. Now, if you're just documenting the side rails because you have 3 of your 4 side rails up, you need to document that in your daily cares, not here, because here you're saying you have 4 side rails up and you're using it as a restraint. Now down here in chemical, sometimes people click on this, that they're continuing this because say they're giving their patient Ativan for alcohol withdrawal. And they say, well, I'm giving them Ativan and I'm going to click on that. No, you're not using the Ativan as a restraint. You're using the Ativan to treat the patient's alcohol withdrawal, and that's not a restraint. If you're using a chemical restraint, it's entered as a chemical restraint, which we don't do here at St. Joe's. So never say never, but I don't think that that would be appropriate. Again, one more time, what is in your order is what needs to be documented in this section, verbatim. Once you document on that, this is what it's going to look like in your flow sheets. And once you do it, the tab will show up at the top, the restraints for nonviolent. All of this gets filled out. You'll see the section on education. You will need to go in and fill that out on the initiation of the restraints. And then you have the restraint monitoring every 2 hours in the restraint type. This section is what is going to, this section here is what is going to need to be documented on every 2 hours. Now this section is what will show up in your work list, but then you'll also need to go down here and document on this section. You'll click on continued in this section if you're doing your Q2 hour documentation. That's this bottom section for the restraint type does not automatically get prompted on the work list, and we're trying to work on that. As always, there is no getting away from care plans, no matter how much you want to from nursing school. So our BPA, Best Practice Advisory, is going to prompt you an alert. Hey, don't forget to do your education and your care plan. So you can do it from here. For the care plan, it's restraint nonviolent, and you can just add it from here. Or if it's a violent restraint, you can click on, make sure you're selecting whichever is appropriate for the patient. Again, sorry, this is the Care plan, don't forget the patient-specific intervention. This is the documentation for the Q15 minutes for the violent restraints. The restraint tab, there is violent and non-violent, so you want to make sure it's in the right tab. If a PST is sitting with a patient, they will need to search and wrench in the violent restraints. It doesn't just automatically pop up for them. So nursing may have to help them find that the first couple of times. But this is the documentation that is expected every 15 minutes. So psychological status, physical comfort, circulation, continuous observation. And again, this can be completed by a PST, mental health tech, or medic. But if none of those are available and sitting with the patient, then nursing is ultimately responsible. Death reporting requirements. The hospital must report any death that occurs while a patient is in restraint or seclusion. This needs to be reported to risk management. Within 24 hours after a patient has been removed from restraints or seclusion, it also needs to be reported to risk management. In both circumstances, a voice report must be completed. And then this is the number for risk management. You can also look it up in the web directory. There's some information here about our documentation, but I think we've gone over that pretty thoroughly. And that is the end of the PowerPoint. One of the last things I want to share with you is that restraints, if you are in a situation where violent restraints are being applied, and perhaps the situation is that the patient is agitated, they're in the hall, you have to call security. Security is not allowed to apply the restraints. They're not trained to apply restraints. And so only those staff who are checked off in applying restraints are able to apply them. You will be checked off on restraint application. So you should have a worksheet that is a checklist, a competency. So you'll want to make sure you fill that out with your unit and your employee ID number. And then one of the nurse educators will check you off on restraint application. You always want to make sure you can get 1 to 2 fingers between the restraint and the patient's skin, and that it isn't too tight, too loose. We're checking for circulation, things like that. So thank you for listening. I'm glad you're here. Thank you for joining St. Joe's Oakland. We're excited to have you as part of the team, and I am sure that I will see you during your orientation. Thanks. Have a great day.